A trained physician, why does everybody not understand the basics of allergy and anaphylaxis?
It's a great question.
What sort of advice do you give to people who are struggling to okay, the two systems, or the nuance that comes in with that chart?
If you have a trusted relationship with your allergist, and I hope everyone here does, but if you have a trusted relationship with your allergist, say, I don't know about the steroids, and here's why. I saw this study that maybe it's not that beneficial in the case of anaphylaxis.
Welcome back to EpiPod. Danielle's had anaphylactic food allergies her entire life.
And Sarah is a food allergy mom to 2 kiddos.
Managing this invisible health condition can feel so isolating.
Do you also feel like you have a degree in overthinking?
If you're nodding your head like me, then you're in good company.
Let's get you off that allergy island right now with people who get it.
Ready to dive in?
Hey, Danielle.
Hi, Sarah.
I am so excited for today's episode. I love a guest episode. Maybe it's my journalism, background, but whenever I get to pepper people with questions that know what they're talking about, I love it. Brings me joy.
The guest that we have for you all today, before we dive into the peppering of said questions, she is my perfect storm of an allergist. Her name is Dr. Maya GHARFEH, and she is not only a super research-based, aka anti-fear-based allergist, but her child is a food allergy girly as well. And she went through OIT. She's doing amazing. She gets into it more into the episode, but the combination of allergist and allergy mom, you have the MD brain, and she understands all of our shoes that we walk every day.
She is also known as the ALLERGISTMAMA on Instagram. She's a board certified allergist and a mom on a mission to make food allergy care more accessible, empowering, and human.
She has a passion for prevention, patient education, and family-centered care. She blends clinical expertise with lived experience to support parents navigating allergies in real life. Through her online community and the Allergist Mama membership network, she shares practical tips, evidence-based insights, and honest reflections from both sides of the exam table.
I am so excited for you guys to hear this conversation.
Dr. GHARFEH, welcome.
Hello, so great to be here.
Thank you for
so
being
much.
here. I love following you on your Instagram page, and we'll make sure to, of course, tag all of that. But I think we've said this before, Danielle, that whenever we have somebody on, to me, it's crucial that not only are you a smart person who can talk about the topics we're talking about, but to have the experience of being someone who either A, suffers with allergies yourself or is an allergy mom, parent. It makes it so much better because you get it. You truly get it.
Yeah.
So maybe we start there. Your daughter has food allergies, right?
Yeah, so crazy. I can't believe that it happened to us, but during actually my fellowship training for allergy and immunology, my daughter was probably about 9 months old when we first found out that she has a cashew and pistachio allergy. And it was kind of one of those moments where I'm like, there's no way. There's no way that we come from a Middle Eastern background where we eat a lot of cashews and pistachios in a lot of our food and desserts, that my daughter would have a cashew allergy, and I'm studying to be an allergist. There's no way. But truly, she was very positive on her testing, and then unfortunately had an accidental exposure to cashew not long after her initial diagnosis, and resulted in full-blown anaphylaxis. To me, it almost seemed like a godsend for me as an allergist to be able to witness firsthand how severe these reactions can be, and how well epinephrine worked to stop the reaction. But in that moment, she had all the symptoms: runny nose, sneezing, new cough, wheezing, hives head to toe, and became lethargic, honestly, in front of me. And it was very scary. And I gave her Epi. We went to the closest source that was next to us, which was an urgent care. And then we went to the emergency room after that. And, having lived that firsthand and experienced that firsthand, and of course now we've grown from that, has been so instrumental for how I approach, of course, Olivia in her allergy world, but my patients, because I get it. I've had to use Epi. I've actually had to use it twice on her. I've used Epi on her a couple of times. We've had near events, especially when we were doing desensitization for her. And so I get it from a very real standpoint as well as a professional standpoint.
Yeah, I'm so sorry that happened. Recently had an experience similar with my child, and it's just unlike any other. It's really hard to explain, I think, to anyone who doesn't understand it. But I know a lot of people listening who are nodding their heads and can just like feel your heart right now talking about that.
Yeah.
But also the fact that, the patients who come to see you, I hate to say, you're not lucky to have gone through that, but in a sense, they're lucky to now have you who's had this experience and have that really like understanding of the gravity of what that means to see your child like that.
When you say, how old is Olivia now?
So she's about to be 10 next week.
Oh my gosh, yay, happy birthday. And you said she went through desensitization?
She did.
Choose OIT or?
Yeah, we did. We chose OIT. So when she was diagnosed, we were living down in Houston area. That's where I did my fellowship. And then we moved up to Waco and then moved up to Oklahoma City just about 5 years ago. So when I moved up here, one of my partners actually did the food allergy desensitization. And a big part of why we had to wait until that time is there wasn't anybody in Waco at that time that was doing food desensitization. And I certainly didn't feel comfortable doing it myself on my own child. And so I was very fortunate, very, pleased to have joined a practice that was performing OIT. And, call it what it is. I didn't feel comfortable doing OIT on patients until I walked through it with Olivia first. And so having walked through that with her really gave me, again, a firsthand experience of what I'm now prescribing and doing quite routinely with my patients. But she reached maintenance OIT about, it's been 4 years now. Wow. And so she takes her doses most days of the week. There are many days that we forget, but she's had really dramatic improvement in her skin test scores and in her blood testing. And so we've backed off on the daily use of it. But it's been a dramatic improvement for our quality of life.
That's amazing.
Yeah.
I also think it's important, you said that you, even as a trained allergist, didn't feel comfortable doing it for your own daughter. And I have an Instagram page where people message me things all the time, and I talk about treatment on my page. And when I tell you how many people ask me specific questions because they are interested in trying their own at-home program,
yeah,
I'm like, please stop.
Please don't.
Absolutely not. I will not share any information with you. Is there a way to report this person? I'm like, no, you cannot do this. Yeah. So to all those people who are even thinking a little bit about that, no, she doesn't even do it on her own child. Come on, people.
Yeah,
it's bananas thing I've ever heard. That's like call CPS now.
Yeah, it's pretty wild. I mean, people, I think there's a mentality with OIT that, just feed them a little bit of it and they'll outgrow it, and I think there's a seed of truth to that, right? I mean, there's a piece of that I think that is what we do with OIT, but we do it in such a controlled setting, really knowing what amount of extra allergen exposure is likely to be safe and tolerated, and then when maintained, allow the immune system to develop tolerance and then increase that dose in a stepwise approach. So it's not quite as simple as, just give them a little cashew and they'll be okay with it. And another piece of that is that we don't have a way of quantifying what every patient's threshold is for allergy. Some patients actually, even at the beginning, have a higher threshold than other patients. But we don't know what that is. And so because the risk of anaphylaxis is so present, it's not something to play with. It's not this light thing to play with.
And speaking of all of that, which I feel like kind of is a good segue into something I personally want to ask you a little bit about, is, the fact that allergy is such a specific science. And I know that most medicine is, but when you have this risk, you're like teetering on the edge of anaphylaxis with just general life, and then also with any kind of specialty program you're doing, whether it be OIT, TIP, or something else. My son's recent reaction was related to his treatment. Mm-hmm. And when we went to the ER, and then we went afterwards, and for not related, but went into our pediatrician's office, who we love. We've seen like ENTs and pulmonologists, like all these different specialists for other things related to my son. But when that reaction has come up in conversation, it's very obvious that there is some disconnect there, or some lack of full understanding of treatment programs or anaphylaxis in general. I'll share just briefly, and then I want to hear everything you have to say about it. But when I was in the ER with my son, the doctor was saying that it probably wasn't even anaphylaxis because my son didn't have hives.
Oh.
And I thought to myself, I'm like, I don't think you have to have hives. I'm like, I'm pretty sure every conversation I've ever had with an allergist has said that, while a lot do, you can very well have two other systems at play and need your EpiPen and have had anaphylaxis. And so it just struck me as odd that a trained physician in a large hospital ER, specifically a pediatric ER, didn't know that. Whereas I am not clinically trained at all, and I knew that. And then, to have him kind of also put that, I don't know, seed of doubt in me as a parent that I did the right thing, was hard. And then finally, when I put that or shared that on my social media, the flood of messages I received from people saying, that was exactly our experience, or we had something very similar, we were talked down to in the ER, somebody told me, why did you use the EpiPen? It's these mixed messages from people that I'm like, okay, do I listen to my training from my allergist that my son has, or am I listening to this trained medical professional in an ER setting? And then now I'm confused because, again, I don't have clinical knowledge, and it's just so difficult. So I want to hear, that was a lot of build up to this question of why is there a disconnect? Why does everybody not understand the basics of allergy and anaphylaxis?
It's a great question. It's a great question. And you're absolutely right. It's not unique to your situation. I shared with you in my response to your message when you shared that. I've had patients in anaphylaxis from an OIT dose. I've walked them to the hospital after mom has given the epi, only to have the hospital ER not really address the anaphylaxis, and the child actually have a biphasic reaction, and I tell mom, go ahead and give him his own epi, because the ER staff was not attending to his anaphylaxis at all. So, I've seen it witnessed. It's very frustrating. It's incredibly frustrating. To make it, clear for everyone that's listening, anaphylaxis is defined as a severe allergic reaction in response to an allergic exposure that is defined by having two or more organ system involvement. So you're absolutely right. You don't have to have hives, though often it is present, but the presence of lip swelling, the presence of new runny nose, upper respiratory congestion symptoms, new cough or bronchospasm or wheezing, new vomiting, new even nausea, nausea and cramps. Any of those two or more systems qualifies as anaphylaxis. And if you as the parent are concerned that your child had this exposure and doesn't look right, you're going to use Epi. So, I mean, we teach as allergists, when in doubt, use the Epi. If you know that your child had an exposure to your food allergen or a medication or a stinging insect, you know that their exposure was to an allergic trigger, and they have this reaction, if it's 2 or more systems or they just don't look right to you, use Epi. Epinephrine is life-saving. It is, when it's used quickly, it quickly stops the reaction. And any bad outcome that we see from anaphylaxis usually boils down to, why did that happen? Because epinephrine was used too late. So it should be used quickly. It should be used without any question. And there should be no hesitancy about that. Now, why is the treatment so variable from emergency room to emergency room and provider to provider? I mean, I think this is just, unfortunately, the state of where we are. I mean, there's a lot of gap in knowledge on allergy and food allergy specifically. As far as how anaphylaxis is defined, there's a huge gap between how allergy providers define it and how ER providers maybe attend to it. But there's also a lot of gaps in knowledge as far as what even is a food allergy. Many providers think a food allergy and food intolerances are the same thing. There's a lot of gaps in knowledge as far as testing for food allergies. So there's a lot of room for improvement in this world of food allergy specifically. And so it is absolutely important that we as providers in allergy specialty care do our job of teaching our patients how to handle anaphylaxis. And as the patient, they should feel absolutely empowered to care for and to treat their patient as they are taught by us as allergists for anaphylaxis, without a doubt. Now, they're going to meet some questions when they interface with ER. Hopefully not, but when and if they do, they should still stand on the truth of what we know and what we teach about anaphylaxis. And I did a little bit of research to see, why is there such a variable standard? And it seems, part of it is there's not a standard of care for emergency room care of anaphylaxis. So some hospitals have adopted more of a standardized treatment plan. Think of it like a patient that comes in with signs of stroke, or a patient that comes in meeting SIRS criteria, or septic shock. So there's very specific, if you meet these criteria, then you get fluids and you get, pressors, all of these different treatment options dependent upon what your symptoms are. And I think that that's something like that, if not already implemented in an emergency room, would be helpful. If a patient comes in, first question, did you have, signs, symptoms that suggest anaphylaxis? Did you have an allergic trigger? Second one, how many systems are involved? If they're able to quickly triage that and it meets criteria for anaphylaxis, it should be first treatment, not steroids, not Benadryl, Epi. It should be first on that list. But yeah, I think some procedural changes would be helpful. And then, of course, some more educational opportunities would be so helpful.
Yeah. Is it up to the individual hospital to put something like that in place? Or is there some bigger, greater body that institutes things like that?
I think generally it's up to the hospital. Now, if it's a hospital that's owned by a larger group, then it would be up to that larger group. But generally speaking, like in our area here, it would be up to our Mercy Hospital or if Integris Hospital. So it would be up to the big hospital system to decide these are the anaphylaxis protocols that need to be in place. And when they're not followed, then it needs to be checked as to why. What were the reasons that it was not followed, and what was the outcome too?
And maybe this isn't unique just to allergy, right? I'm sure there are other people out there that deal with other things where there's not this like standard protocol across the board like there is for stroke. But I even think about, I follow allergists online that, post a study about how steroids actually aren't that helpful in an allergic reaction. And yet again, not only is it prescribed to me through my treatment program for this, or to my son in his treatment program, but also in the hospital, I was given for him steroids and a prescription for them to take later. And then, again, it's this like push and pull of like, okay, I'm given this information from a trained professional, but then again, you're seeing these very knowledgeable allergists online saying, actually, maybe that's not the right thing to do. So from the patient perspective, I mean, what do you suggest they do in that scenario? Follow the person they trust that's a trained allergist, or follow the ER? I mean, you can't give medical advice, but like what's a parent to do?
I think you have to circle back to your allergist. The allergist that you follow on social media, or maybe that you're friends with even, they're wonderful. They're giving, and I'm one of them. We're giving the up-to-date information, right? But I don't know your case specifically. I don't know exactly what happened. I'm not caring for your child. And so I think the question always goes back, if you have a trusted relationship with your allergist, and I hope everyone here does, but if you have a trusted relationship with your allergist, say, I don't know about the steroids, and here's why. I saw this study that maybe it's not that beneficial in the case of anaphylaxis. Do you think we really need it? And see what they have to say about that. And I would think that most of the time, a trained allergist that handles OIT or TIP, or does a lot of food allergy, would feel comfortable addressing that question, and then telling you not just, yeah, we need it, or no, we don't, but telling you the why. So helping you understand why that might be more beneficial in your specific case.
Yeah.
Well, I think it's just absolutely wild. I pulled out my phone. I was like, let me just Google, let me hop on the FAIR website. 33 million Americans live with a life-threatening food allergy. 1 in 13 children have a life-threatening food allergy. And this is the part where I'm like, how is this not standardized? Like all of the things that you were talking about, can we triage these 3 things? If it's not followed, then why? I'm like, well, this all makes sense. Every 10 seconds, food allergy sends a patient to the emergency room.
Wow.
So when I hear this, I'm like, wow, so how many, a lot more than, we've been here for hundreds of seconds, okay, just in this conversation so far. If every 10 seconds somebody is sent to the emergency room for a food allergy, that's discounting all the other people who didn't go, stayed at home, addressed it themselves, whatever. How many of these conversations are, like, how many thoughts are running through the parent or the food allergy adult on the other end as the patient, being like, how does this happen this often and affect this many people in our country alone, and it's not standardized, or
it's not standardized. Yeah.
It's crazy to me. Another thing so I have had peanut and tree nut my entire life. I'm 33. I did not know. I'm a 90s baby. I didn't know to carry an EpiPen until I had an incident that sent me to the hospital. And then I was like, wait, this can take my life. I need to carry this thing. And so now somebody who has gone from one end of the spectrum thinking oh, it's like my lactose intolerance. You take a Benadryl. Now on the other end where I'm just literally fighting for my life against my anxiety of well, what if this happens? I have the FAIR action plan from my allergist on my cell phone as one of my background options. So if ever, this was mostly when I was in OIT for a little under a year and a half, and it was not for me. The amount that it made my world smaller instead of bigger. And that was something that before I even started, in the intake day, my allergist was like, if this makes your life smaller, not bigger, this is not the right fit for you. And that was playing in the back of my head the whole time. And I finally was like, okay, raise my white flag. this is not for me. At least not at this time.
Yeah, that's okay. That's okay. Yeah.
But looking at the FAIR chart, 2 systems. Say I don't have hives, but I'm sneezing and have a ton of, runny nose, and my lips have a little swollen thing. Even Sarah, taking her youngest to her OIT appointment just this past week, he had you can go more into detail, Sarah, but he said his tummy hurt, and they think it was mostly from contact, but his lips were swelling a little bit.
Yeah.
So to me, and he didn't epi, and it was fine with a Zyrtec, and he then the rest of the week did great with his at-home doses. So I think that was something that was really challenging for me doing OIT, but now just as like a human living with allergic disease out in the world, looking at that FAIR chart and hearing the words you've just said, where I'm just like, okay, if it's 2 systems, but then you hear, you know, or it's like, is it bad enough? Like a little contact and this, like just one sneeze, like that just seemed so hairy-carry. So if I were, whether it's like your child, your sister, or your patient, like what sort of advice do you give to people who are struggling to like, okay, the 2 systems, or like the nuance that comes in with that chart?
It is nuanced. You're right. It is nuanced, and there are, you know, settings like, you know, Sarah, what you experienced with your son in the clinic. I mean, there are cases where we're gonna maybe watch it a little closer before we do the epi. But I think if I could give the advice, it would be that, again, if you're in doubt, just use it. I mean, there's not going to be a case where you're going to say, I really wish I hadn't used that epi. And now that we have Neffy, you know, and we hopefully are about to have the under the tongue option too. These are options that are pretty, you know, they're not as scary as using an EpiPen or an AviQ pen, a needle. They're not needle approaches to epinephrine. So it's a lot easier to just use it, and then monitor symptoms closely. Anaphylaxis guidelines were actually updated last year. I think the end of December, it might have been 23, but updated so that if epinephrine is used, you don't always have to go to the emergency room. So I advise my patients, when you use your epinephrine, watch very closely for the next 15 to 20 minutes. If the symptoms are getting better, then just watch at home very closely again for the next 2 hours, because we know that allergic reactions typically by definition are going to kind of reach their height in 2 hours. We used to be very worried about the biphasic reactions and that was why we recommended ER visits. But the reason the anaphylaxis guidelines were updated to say not everyone needs to go to the emergency room is the prevalence of biphasic reactions is actually pretty low. But of course, you're going to keep an eye out for the 2 to 4 hours, but really breathe much better after the 2 hours have passed. But yeah, I mean, if you use the epi when you're at all just kind of saying, I'm not sure, something doesn't seem right, I think that's a good baseline. You know, very few patients are going to overuse epi. There's those few, and that's where, as allergists, then we come in and say, okay, we don't maybe need it every week, but you know, we can do some teaching, or maybe the child does. Maybe we need to re-look at what is going on at home. Why are they getting exposed to their triggers that often? But most of the time, people aren't going to overuse their epinephrine. And so if they're not, and they can kind of learn to recognize what are these big reactions that, and maybe not, I should clarify, maybe not a big reaction, but what are these reactions that are resulting in needing of epinephrine versus maybe a just skin finding reaction only, you know, or tummy ache is tough because kids can have tummy aches from so much. But maybe it's just a little skin reaction. We give a little extra dose of cetirizine, monitor, see how things are settling out, and just kind of continue to go from there.
I want to talk a little bit about these programs that you've developed. Both, you said, you know, different tiers or levels of it, but one is specifically for providers, right? Or is it for any type of physician, like any kind of person in the medical field, or is it specifically for allergists? And I'd love to hear what you're teaching or sharing with them that might be helpful for, you know, the average person out there either living with allergies or who has a kid with allergies.
Yeah, so I've created a kind of a non-social media based network, and I call it the ALLERGISTMAMA network. But the idea of it is that I want to be a hub where we can land resources for providers, so a tier for providers and a tier for patients and families dealing with food allergies, but a place where we can be guaranteed evidence-based information on all things food allergy, a discussion forum that is not quite as open ended for all the things that maybe Facebook groups can do, but is guided by someone like me, someone that is, trained in allergy and immunology, board certified, and does OIT. So guided through that, webinars, courses guided specifically for providers and or for families, depending upon the tier. But the idea of this is that I don't want it to be lost by the algorithm. I don't want it to be lost by, just in case you were wondering what is going on in the allergy world, it might pop up on your feed. I want it to be a place that is a permanent place. Because honestly, the food allergy world is changing all the time. I mean, 10 years ago, we didn't talk about OIT that much at all. It was when I was doing my fellowship, it was just in the research setting that it was being done, let alone Xolair and let alone, all of these options that we have now. So the options and the world of food allergy is constantly changing. And it's hard for primary care providers, for GI providers, for, even parents to just stay up to date on the evidence. And so that's where something like that, I'm hoping that through that network, we can have a safe place for that evidence-based information and just continue to grow and address some of those gaps in knowledge that unfortunately we continue to see.
Yeah, I mean, I just think something like that is so needed, especially for those, whether it be a pediatrician or somebody outside of the allergy space. I just know it would help so many, if there happens to be anybody out there listening who is a provider of some kind, it's like having that extra evidence-based research and knowledge about something that, like you said, Danielle, so many people in this country are managing and dealing with. I mean, it would make a world of difference, to feel as a parent, to have felt really supported and understood and cared for in the correct way, in that ER. It would have been a game changer. It would have definitely made me feel a lot better about the entire situation.
Yeah.
I love that you're using words like evidence-based, research, moderated, because I have had to, as somebody who's living with like extreme food allergy anxiety, I've had to mute literally every single allergy account because as a social media marketer, I have worked professionally, both corporately, freelance, as a creator myself for since I was midway through college. Like I have no other experience other than digital marketing.
Wow.
And so I know how the algorithms work.
Yeah.
The more, fear-based openers and more fear-based words you use, the more you're rewarded by the algorithms. So I see even allergists use these words, or like the opening sentence is just as freaky and irresponsible as the news headlines, where it's just like, she died and because the EpiPen wasn't enough, or things like that, where you're just like, well, the people who are consuming this, the people who followed you because they live with this themselves or their child does, now this happened to me personally, like, oh my gosh, I have this fear that an EpiPen isn't going to be enough for me. And it wasn't until my allergist sat me down and was like, here's the research. I'm not saying that like you won't be the whatever the correct percentage was where it didn't work, but what are the chances truly, Danielle?
Right.
Like, look at these research studies, like look at the evidence-based knowledge that we have. Like, you have to live on that, not with what Janet in God only knows what basement of, some different country has like said, because the algorithm is rewarding her for this incensatory language. Is incensatory a word? I'm not sure, but if it isn't, it is now. So just like as somebody who reading the research is all unfiltered as an untrained professional, as somebody who wants to know the research, it's a lot. Like the barrier, I don't know. I'm spending half the time like looking up words on like Webster, WebMD. So just as somebody who I'm neither a parent nor a medical professional, I'm like, sign me up for the mama group.
Yeah, and I mean, you bring up a really good point, and then think about also the parent that doesn't have the resources to get into the top allergists in the city or the state, and but they're probably on their phone. And do we need to rely on the algorithm, like you mentioned, that's just going to feed them fear-based information, or can they go to a place that has the evidence-based information and they can actually care for their child from a place of peace, a place of knowledge, rather than a place of anxiety and fear? And so, yeah, I mean, it's my dream. It's been my dream to do something like this for a long time. Education, I took a little sabbatical between my second and third years in medical school, and I got a master's in public health. And so maybe that's why I'm such a nerd for education, but I'm a nerd for education. And I think we can always grow. We can always learn. That applies for me. That applies for, my friends and colleagues that also practice medicine, applies for parents. We all could use more knowledge, and that is, yes, guided by evidence, not by fear.
Yeah. Thank you so much for having that resource. And I hope it grows and people lean on that versus a Facebook page or something else. And then as well, that different types of providers will lean on that kind of evidence-based research to further their understanding for their patients. Yeah. I want to say, I know we've taken a good bit of your time to talk about this, and you did mention, using the Epi and feeling like strong in your relationship with the allergist that you trust. But is there anything else that you would say that parents or patients themselves should do when faced with a provider who is not fully understanding allergies and doesn't give them maybe the advice that they feel pretty strongly they heard, differently from their allergist previously? What can people do in that situation, or what do you recommend to them?
So you're specifically saying in the emergency room setting?
I mean, honestly, wherever. If they're in an emergency room setting, or say they're at the pediatrician's office and kind of being told something or talked down to in a way, about things that they just either don't feel is accurate in regards to allergies, or, or kind of telling them that they're too much or overreacting, something along those lines. Like, what should patients do?
I mean, I think in any kind of doctor-patient relationship, it's always worth first having a conversation. If you as the patient feel there's a disconnect, there's something that you're not hearing me, or you physician are not hearing me, I have these concerns, I feel like they're not being addressed. I always think the first step is just talk to them about it. Say, hey, I would like to discuss this further. I feel like we have a disconnect as far as how we approach allergy. My allergist states X, you seem to say this. Help me understand where that barrier is, or where that gap is. And so having that first healthy conversation, I think, though no one probably wants to have it, I think that's an very important step to take, because it may be an opportunity for growth for that physician. I mean, we're all people. We're all human. We're all able to make human error, right? And so that allows for an opportunity for growth. If that conversation does not go well, you feel still not heard, you feel that connection is not going to work, I mean, you are certainly empowered as a patient to choose a different provider that does meet your needs, that you do seem to connect well with, I should say. Because again, all relationships are going to be unique. I might not mesh well with all people, and same with people to me. So it depends on how comfortable you are having that conversation, and then how comfortable you are maybe finding a different provider if you feel the need to do so. Now, in the emergency room setting, I think it would be a little bit different, because at the end of the day, they're there to save your child or your life. They're there to get you to a place where you can be either admitted to the hospital safely or discharged home safely. That's the role of the emergency room provider. I think you, again, kind of state your concerns, but at the end of the day, we kind of have to, in the emergency room, hand that care over to the provider in there, because we know that at the end of the day, they're responsible for what's going on. Now, hopefully, if it was anaphylaxis, they've used epinephrine. And I think it would be very rare that a condition would progress and not be treated with epinephrine, even, at some point in the emergency room. So I think that it would always it would most of the time happen that you would eventually be treated with epi. Maybe not right at the beginning, but hopefully at some point, if the condition continues to progress, anaphylaxis continues to progress, that you would be eventually treated with epinephrine. But that's the part of the trust in the healthcare system that, as honestly as a physician, I hope we don't lose completely, because we need those ER providers to save my kid's life. I cannot think clearly enough as a parent when I bring my kid to the emergency room to save their life. But the unbiased ER physician, nurse practitioner, that's their job. That's their job to do that. And I need to be able to trust them to do that. And so there is, some of that's very important. But in a practice standpoint, outpatient standpoint, when you are building a relationship with provider to patient, I think having those open, healthy lines of communication are so important.
Yeah. Thank you for that. I think that's great advice, and so very true. And yes, whenever I had that instance in the ER, I mean, we would never have pushed back. If you would have said your son needs this medicine, I would have said, great, give it to him now. It was not believing him, and more of a just frustration that he seemed to say things that I'd heard differently from my allergist, who I trust. But like you said, that wasn't an emergent care moment, and he would have done what needed to be done in an emergent moment. And so instead, like you said earlier in the conversation, I can then go consult with my allergist and say, hey, do you agree with so-and-so on this?
Yeah.
So that makes a lot of sense. Thank you so much. And I hope people listening do feel empowered to have those sometimes difficult feeling conversations, and also empowered to use epinephrine no matter how someone makes you feel about it, especially if it's something that you've learned from your allergist is the right move to do in that particular situation.
Yep, absolutely.
I feel like it wasn't until my allergist told me, there really are no drawbacks to using epinephrine. If you mistakenly use the epinephrine and you really didn't need that, there are no drawbacks, but there are extremely could be grave drawbacks if you don't. So for anybody out there who's in the, but I don't know if it's bad enough camp, from your perspective as a medical provider, what are the drawbacks of using an EpiPen and not really ending up needing it?
Honestly, again, I agree with your allergist. There's really not. I mean, you might have a fast heart rate for a little while afterward, feel real jittery afterwards, but I mean, nothing that is catastrophic by any means. And that's why I say, when in doubt, just use it. Just if you are at all that seed of should I use it, just use it.
Yeah. It's a listener fave, so I can't let you go without asking you quickly. In terms of the future of allergy research, treatment, cure, you mentioned neffy and maybe the sublingual becoming available sometime in the future, but it's open-ended. Anything in terms of the future of allergy, where's your mind at?
Gosh, I mean, I would love to just see that food allergy treatment becomes standard, so that all patients are given that option to do something if they were interested in it, some sort of desensitization, if applicable to them, and they're open to it, of course. But just that becomes a standard for all allergists, as standard as allergy shots are. I would love to see that treatment just be kind of more standard. And on the other side of it, I would love to see the numbers go down. I would love to see food allergy prevalence go down with all of our earlier exposures to the food allergens in our infant population. And part of that is going to depend upon primary care providers and, the initial interface with these patients of not over testing for foods without history of reaction. So that's kind of a soapbox I love to stand on. But, a lot of this unnecessary early testing, panel testing for foods leads to misdiagnosis and overdiagnosis for cases that maybe we're never going to develop food allergies. So that would help us hopefully also decrease some of those numbers.
Are you hopeful of those things?
I am.
think that's going to actually happen in the future sometime
I am
soon?
for treatment. Yes, I think that is. I mean, it's making a lot more headway than it has, and I'm hopeful on the numbers. I mean, that's another reason why I really think that education to the forefront providers is so important. But I'm really hopeful.
Thank you again so much. It was such a joy talking to you.
Thank you, guys.
That was epic. Thank you guys for tuning into EpiPod today. As always, we will recap and link everything that Dr. GHARFEH said and mention that we would be linking in the show notes. You know where to find us on Instagram, on YouTube. You can listen to us on Apple Podcast and Spotify.
Thank you so much to Dr. Maya for coming on and spending time with us. And if you have any additional questions, send them our way in an email at epipodpodcast@gmail.com. And we'll see you next week.
See you next week.